Welcome to Dental Business RX. Practice success in 30 minutes or less.
Thank you for calling ABC Dental.
Hi, everybody. Jeff here. And for this week's episode, I'm going to be discussing what I like to call a niche question, meaning a very specific question about one aspect of practice management that we get from a lot of clients, especially when they add an associate doctor. You know, clients adding an associate, the offices become busier. So the usual initial discussions are how to integrate this associate. And one of the first questions we get is, should I let my associate doctor present treatment plans? And the answer to that question is yes or no. I mean, I know that sounds kind of stupid, but it really is a yes. It is a yes sometimes and a sometimes no. It really depends on how the client is going to utilize that associate. So that's what I want to talk about in this week's episode. Specifically, I want to talk about when you should and when you shouldn't let your associate present treatment plans. I want to go over the role the treatment coordinator, based on the level of experience they have and skill, plays in all of this, as well as how, based on your situation, you can implement this in your practice so that you end up with a good outcome. And I think the best place to kick it off is, why are we normally asked this question, whether the associates should sell or not? And maybe that's a bit of a no-brainer, but if you take a look at it, the office is busy. Maybe there's 3 hygiene chairs going. The practice is getting 80, 90 new patients a month. The doctor owner can't keep up with effective treatment presentations at that point, so they're going to have to start passing some of that off. Usually how that represents initially is maybe they've got a decent treatment coordinator and the doctor starts short-circuiting their presentation a bit. Not in a bad way. Maybe they're not spending as much time getting into financial discussions and things like this as they present treatment, and they're leaving that to the treatment coordinator. We discussed in episodes 73 and 74, I think it was streamlining the case acceptance process, sort of the whole process from beginning to end as far as, the ideal setup for a solo practitioner presenting dental treatment in a dental office, what the doctor should do, what the treatment coordinator should do, and so on, the whole process. And maybe they don't have as much time to spend doing that anymore is one of the things they're finding, and their treatment coordinator's picking up some of the slack and they're seeing some inefficiencies there. So they're thinking, okay, I need the associate to do some of this stuff because I can't do it anymore. So this is usually when a client asks this, when we have to take a look at how the client wants to utilize this associate. And let me explain what I mean by that. And I'm sure there's different ways of saying this, but there's essentially 2 basic relationships that you'll see in the MGE client bases, or client base rather, between owner, doctor, and associate. We have what we call a conventional setup, and we have a production doctor setup. And I think I mentioned this in one episode a while back. But essentially, if you're adding an associate doctor, you have to decide what they're going to be doing. So a conventional setup would be the associate owner-doctor relationship that we've seen for years and years. Maybe you're bringing them in, you're acting as a bit of a mentor, it's a newer practitioner, and they're coming on board, and you're going to teach them some things, and they're going to do the work that you don't want to do anymore. That you're going to give them the molar endo, maybe they're going to see emergencies, they're going to see kids, they're going to be on call, things of that nature. This is the setup. So that's the conventional setup. In some cases, that setup requires the associate to bring in some of their own new patients, and if it's their new patient, they can present, and some it doesn't. It really depends. And sometimes in that setup, the owner doctor is still doing all the presentations, right? But in the conventional setup, the associate doctor is normally making 30%, or a base pay and some type of an override. But they're normally making 30%, which is a decent percent for an associate to make. So that's conventional. In a conventional type setup, the associate doctor is going to end up doing some sales, especially if the office is very, very busy. And I'll get into the production doctor setup in a second, but let's talk about this conventional for a second. So if I have an associate doctor I've brought in and I'm expecting them to do some sales, well, then my next question would be how is your treatment coordinator? If you have a strong treatment coordinator who's good at closing, then this could potentially work. I'm still going to train. If this associate doctor is going to do sales, I'm going to want them to get trained to sell, because it's kind of silly if I'm going to let them loose on the patient base without the proper communication skills to get treatment acceptance. Otherwise, you're going to end up with just continuous lost opportunities. It especially doesn't work if the doctor owner is not staying busy and they feel like they have to keep the associate busy. So they're giving patients to the associate doctor they could have seen. And that associate doctor is blowing the close on these because they're not very good at closing. Okay. So in any event, I'm going to want to train this associate on sales. But let's say I have a strong treatment coordinator, right? Well, in that case, most likely what I would want the associate trained on that I could do myself before I let them loose on patients to present treatment plans is I would want them to at least get to the point where they could comfortably explain to a patient what was wrong and explain what the dental treatment solutions are for this problem, including, answering any questions the patient might have about that treatment. Okay. So if they can do that, and this may sound like a no-brainer or kind of silly. Well, of course everybody can do that. That's absolutely not true. I've met doctors that can't even look at you when they're talking to you. I remember my wife had to go see the ENT. So an ENT, this person's been through, their undergrad, 4 years medical school, 4 years residency, and I don't know how many years, 2+ years specializing. And this fellow is a really good ENT, but he couldn't look. He looked at the floor the whole time he talked to us. Thankfully, we were very interested in hearing what he had to say. If we weren't, I don't think we would have gotten anything he said. So, you have to have it so the person can at least comfortably discuss these things. We had one client who had an associate that was uncomfortable meeting new patients. So this client spent an hour role playing with the associate how to meet a new patient until they felt comfortable with it. So I would advise you do the same thing. If you have a strong treatment coordinator who can close and you want your associate to help with sales, you at least need to have them able to comfortably talk to a patient and tell the patient what the treatment plan is, what the problem is, etc., and communicate it in such a way that the patient is going to understand it. And how are you going to know this? Have them explain it to you. And you might see some silly things right off the bat. They start off and they say, well, if you look at your x-ray here, here's a periapical radiolucency. You're going to go, well, I would never say that to a patient because they're not going to know what I'm talking about. Or they might use the word abscess instead of infection. Things of this nature, things that aren't going to fly because you're the owner doctor and have been doing this for a while. With a patient, you have to kind of, work with them so that they get used to how to do this properly. So if I have that strong treatment coordinator, I'd at least get the associate able to meet a patient, explain what's wrong, explain what the treatment solution is, and then how to pass it over to the treatment coordinator so it doesn't get awkward. Then they can start helping you sell. But I would require that meanwhile, they're getting trained to sell. As far as how you can get them trained, here's my shameless plug. We have sales training on our online platform, DDS Success. I'll put a link to it on the episode webpage. We also have the MGE Communication and Sales Seminars, which a lot of our clients sends their associates to. Again, we teach, doctors how to get better case acceptance, right? Get patients to want what they need. I'll put a link to that as well. But so strong treatment coordinator, I'm training them how to sell, but while I'm training them how to sell, I am having them help me with sales because they can at least explain treatment to patients and tell patients what they need. I have seen that setup work. Ideally in that type of a setup, I'm not giving this associate doctor really large cases to present. I would be doing those myself because I want to make sure that they have a better shot of closing at that point. That's assuming I know how to sell. And then as they get more and more trained and more experienced, it works. But this brings us to this whole idea of, do I have a strong or not so strong treatment coordinator? And this is something to think with. Let's say that your treatment coordinator isn't very strong. They're not very good at closing. They have a hard time discussing finances with patients. Maybe they're just a little rough around the edges. They don't know exactly what they're doing yet. Well, you're going to have to train and apprentice this person as well. We do that training as well. But still, you're going to have to kind of work them through it so that they feel comfortable doing this. If I have a client who's got an excellent treatment coordinator and they've been working together with them for a long time, just to give you an example, doctor, great at sales, treatment coordinator, great at sales. When they present a case, the treatment coordinator doesn't even have to be there for the entire presentation. They probably would be if it was an FMR case or an all-on-4 or something like this. But if it's a $4,000 or $5,000 case, the doctor just presents it, brings them over to the treatment coordinator, or the treatment coordinator pops in, and it's turned over and done deal. 9 times out of 10, that closes. Why? Because the treatment coordinator can close. They also have seen how the doctor handles various types of objections and questions from a patient. Do I have to do all 6 crowns now? Can't I do just 2? They've seen the doctor handle that 50 times, 100 times, so they know exactly what to say. But the way they got to that point, which is kind of my point here, is they were with the doctor for entire presentations for quite some time. So Let's say you have a doctor who can close and they have a newer treatment coordinator. Well, that treatment coordinator should be stuck to you like glue when you're presenting treatment plans. They're there from the beginning. You sit down with the patient to present treatment and you introduce the treatment coordinator. This is John or Susie. He or she is my treatment coordinator. And, they're going to sit in with us today because she's going to help us work out getting your treatment scheduled and getting everything taken care of. And then John or Susie, whoever your treatment coordinator is, watches you present the treatment plan, watches you answer questions, watches you address objections. And then they can replicate that process in the future. So that's how you end up, create that plus training. Okay. Which we also, a second shameless plug of the episode, we do have a treatment coordinator training course on DDS Success, which you already have a link to. But they're trained. They've watched you do it for a while. You had done it successfully. They've had wins at it. Well, now you have somebody who can actually close and you have a great relationship. So then when you add that associate doctor, while they're learning to sell, that treatment coordinator is sort of picking up the slack so that you're able to, increase production markedly because you're able to address more patients and close them. You might need to add a second treatment coordinator if it gets super busy. So in a conventional setup, which is the setup we've all been used to, it was the setup when someone told me they were adding an associate when I first got into the dental industry in the 90s. That was what I was expecting, the conventional setup. This is the junior doctor coming in, you're mentoring, etc. Then yes, they are going to have to learn how to sell. Okay, absolutely. And yes, they are going to have to sell, but you don't want to just let them loose with zero training. Now, sort of a variance of this that I've seen over the last few years that I just want to make mention of in the conventional setup is you'll see situations where someone adds an associate doctor, and I'm not even talking a specialist here, okay? I'm talking an associate doctor who does procedures that the owner doctor does not do, okay? For instance, maybe the owner doctor doesn't place implants, whereas this associate does, or the associate does, well, I guess implants as well, all on fours, things like this, whereas the owner doctor does not. That's not a bad setup, okay? Where it becomes problematic is when you pour tons and tons of your marketing dollar into that. I just want to make mention of this because it's something I've seen people do and it's a bit of a mistake. And usually that type of an associate is going to come with a higher price tag because, let's be honest, they can do something that you can't do. For example, I remember seeing one doctor bring an associate in who could place implants when they could not. So they're paying this associate 40%, which in my opinion is way too high. That's like specialist type money, and I even see specialists take less than that now. So what this owner doctor did was they diverted a lot of their marketing money to implants because now they could place implants in the practice. They couldn't just restore them. So this was great, right? Because implants are a higher ticket item and they had all these patients that they were referring out. The problem was they were losing 40% on each of those implants immediately. So while the production went up drastically actually, the profit margin went down. Not just the margin, but the profit amount went down because everything was being eaten up in the implants. So you want to be smart about this. If you have a healthy basic practice and you add an associate doctor who can do procedures you don't do, that sort of has to pay for itself, and you don't want to abandon anything that you're already doing that's keeping your practice successful, which is why you want to add an associate in the first place. Which, again, if you're going to add an associate doctor who can do things you can't do because your practice is not meeting its overhead or it is not successful, I would never do that. Your practice, if you're a general dentist, you should be able to be successful and profitable no matter what you know how to do. You don't have to learn new procedures. Now, should you? Yes, you can service your patients better. And yes, it's higher ticket items, but I'm more a fan of the prior aspect of it. You can actually do more for your patients, but you should be able to be profitable without having to do that. When you do that, it just adds to the practice you already have. So do not add an associate because your practice is unsuccessful. Terrible idea. So again, conventional doctor, yes, they should help sell, but they should not help sell unless you have a strong treatment coordinator, right? Then you can teach them some basics, but they should not help sell until they learn how to sell. All right, so that's the first aspect of things. Now, there's this second relationship I was mentioning at the beginning of the episode. There's the conventional setup and there's the production doctor setup. And this is why I'm asking a client these things when we're looking at how they're going to integrate this associate. So what is the production doctor setup? Essentially what it is it's the owner doctor moves away from being chairside full-time. They may stay chairside part-time. Maybe they're doing the all-on-4 cases. Maybe they're doing, the more complex implant or restorative or FMR cases. And they're maybe only practicing chairside, 1 or 2 mornings a week, okay? The remainder of their time is spent diagnosing and presenting treatment. And then you have other doctors who come in and they're actually performing all of the treatment that you're diagnosing, except, some doctors keep some treatment for themselves, as I mentioned, the more, complex stuff. Some don't do any. They just have doctors who do the production, and then the owner doctor primarily diagnoses and presents. They would be diagnosing out of recall. They'd be diagnosing new patients. So what that tells you is a couple things. Number one, you would need enough volume to keep an owner doctor busy full time, let's say for a 30, 35-hour week, seeing new patients and patients of record in recall or, patients of record for consultations and so on. All right. That you'd have to have the volume to justify that. So you're probably looking at a practice getting at least 50 new patients a month, if not more. It might be 70 or 80. You're looking at 2 or 3 full-time hygienists, possibly 3.5, in order to keep a doctor owner busy enough doing that full-time. So then they're presenting and then they're turning over these patients for treatment to their production doctors. So now a couple things about the production doctor setup. The production doctor setup is essentially this. The owner doctor is selling, the production doctor comes in and performs the treatment. So number one, you're going to want to make sure that the production doctor and the owner doctor are on the same page clinically. And I say production doctor or doctors. You might have 2 or 3 production doctors. Everybody has to be on the same page clinically. You don't want to sell a treatment plan, have the patient come in to deliver it, and then the production doctor walks into the room and goes, yeah, those don't look like crowns to me. We should just do fillings there. That's just going to be a mess. So everybody has to be of one mind from a clinical perspective. And that's something you can find out early during the hiring process. Normally what I recommend, if you're interviewing an associate and you want to see if you guys agree clinically, is pull out some x-rays, photos, scans, etc., some charting, and ask the associate how they would treatment plan it. Don't show them how you treatment plan it. Ask how they treatment plan it and see if they match. Maybe they missed a filling you would have done. Maybe they would have done something slightly differently. And then you explain, well, this is how I would have done it. And they go, oh, that's a great idea. In other words, if that matches pretty good, you're probably going to be a decent fit clinically. Obviously, you have to make sure the clinical skill is excellent and all that kind of stuff. But that's at least you're on the same page as far as what approach you're taking towards treatment planning, because there are people who take different approaches, and that's fine. I'm not a dentist. I can't really comment on that, but you don't want people who are divergent in viewpoint trying to work together, or it's going to be a constant source of conflict and argument. Okay. So assuming you guys are on the same page clinically, this production doctor is getting treatment plans that you are diagnosing and you are selling with your treatment coordinator, and they basically show up to work and do the treatment. It's actually the dream job. It's the job you were looking for when your practice was stressing you out, right? Or couldn't I just come to work and do dentistry every day? High-end dentistry. That's essentially what they are getting to do. So that position, number one, does not pay as much as the conventional doctor position. Conventional associates getting 30% of production, right? The production doctor is usually getting anywhere from 20 to 25%. Now, when you tell an associate doctor that, they're going to probably laugh at you. Well, the corporate office offered me 35% or 30%, the one down the street, a signing bonus, and so on. The difference is they're going to be producing 40 or 50,000 a month in the corporate office. In your practice, they're going to be producing 100. And they're getting to do the type of work they want to do. They don't have to sell anything. They come in, wash their hands, put their gloves on, go to work, do high-end dentistry all day and go home. So I'll see production doctors making $300,000-$400,000 a year because they're just basically spending all day doing that kind of stuff. The other advantage of the production doctor setup, assuming you have the volume to justify it, is to sell a case. It doesn't take as long as it takes to produce the case. So you can sell, 2 root canals and 6 crowns in 30 minutes. But to do 2 root canals from start to finish and 6 crowns from start to finish takes a heck of a lot longer than 30 minutes. So realistically, if there's enough volume, one owner doctor acting as the sales doctor, okay, could keep 2, potentially 3 production doctors busy. And again, you'd want to make sure with the owner doctor, they have enough treatment coordinator time. As a matter of fact, I can think of one client that works with 2 or 3 treatment coordinators on some days because of their volume, and they have production doctors who end up doing most of the work. I think that owner doctor on Wednesday morning does implants, but otherwise they're just seeing new patients and patients of record full time. And just off of their bat, from a sales perspective, they can keep multiple doctors busy because it takes a lot longer to produce it than it takes to sell it. And it's a great relationship and it works. So if you're going to bring a doctor in as a production doctor, Again, this is if I'm talking to a client and they ask, should I let my associate sell? In that case, I would say absolutely not. You should be the one doing the sales and have the associate doctor do the treatment. So obviously, as in any associate setup, you're going to have to make sure they're an excellent clinician. Assuming they are, well, and you're on the same page clinically, this can work out great. Now, what normally happens in that production doctor setup, because obviously the doctor owner is going to want to take some time off. The doctor owner might, hurt themselves skiing and they can't come to work for a few days or something like this. So then while that's happening, nobody is presenting or selling. So ideally, in the long term, once you start this production doctor setup, one of those production doctors will probably have an inclination towards sales. You might look, let's say you have 2 or 3, things are rolling along. You have 2 to 3 treatment coordinators. You have 2 to 3 production doctors. You have a high volume office, lots of hygiene, lots of new patients. And, the practice is probably doing $500,000 to, $600,000-$700,000 a month because it's just high volume. And you're happy with how it's going. Then you'll notice, let's say one of your associates, you couldn't come to work one day. Had a function or something you had to be at or whatever. So a couple new patients ended up staying on the schedule and this production doc saw them and closed the cases. Okay. Well, then that type of person, you might want to invest some beans into training and teach them how to sell. They're still being the production doctor right now, but then this person could eventually take over for you, at least part-time or when you're out of town, to be the sales doctor. Do you follow? So, they have an inclination towards it. They have a bent towards it. So you could look at this a couple different ways. If I'm an owner doctor and I'm being the sales doc and I have 3 production doctors, I might have them all learning to sell, at least a little bit every week so that they can, learn. I mean, they may not be doing it full time or even doing it at all, but they're at least learning. Or I might take one in particular who seems to have a bent towards it or a little bit of an inclination towards it, or they like it and want to learn how to do it. And I train that person sort of as the backup. Now, how could that look in the long term? Well, let's say I want to leave town for a month. I want to go to Europe for a month. Well, this person's covering for me as the sales doctor and I bring another production doctor in. And then truthfully, at that point, I have a choice. I could just become the CEO when I come back. I take a cut on my profit, but, I'd be more available to do stuff, or I could be a second sales doc or however I want to do it. It gives you a degree of freedom. It would obviously affect your income, but it gives you freedom. But that's the other reason why. One of the reasons why you're not paying the associate doctor 30% in that relationship is because you normally would pay him 30% when you're still a producing doc. Well, in this case, you're not anymore. You're just the sales doctor, so you're paying them 20 to 25%, plus they don't have to do any sales. Well, in that case, with a sales doc, you'd have to pay them something for the cases they're closing, and we have a couple of ideas on that. If you ever find yourself in that situation where you have somebody you're going to transition into the sales doctor position, you can always email me at jeffb@mgeonline.com. I'm happy to give you a couple ideas. But for the most part, if you do this type of a setup, you want somebody who could act as a backup. And so, yeah, eventually, would I want that person to sell? Yeah, but do I have to have them able to sell in a production doctor setup? No. In a conventional setup, yes, the person is going to have to sell, but there are certain requirements I'm going to want to have met before I let them loose on patients from a sales perspective. A lot of that has to do with how strong my treatment coordinator is as I do it. The third scenario that I won't get into too heavily is, let's say you're buying a practice and maybe you're putting an associate in there. Maybe the owner doctor is going to stay for a bit that you're buying the practice from, or you're starting another place from scratch and you're going to put an associate in there. Well, then, yeah, that doctor is going to have to learn how to sell at some point. If I were going to do that and I didn't know this associate too well, let's say you're looking at picking up another location and you go, okay, I want to buy this office and I'm going to hire an associate. And, obviously they're going to have to be able to present treatment to some degree because they're the ones diagnosing it. The way you make that work, the most important thing to me in that setup, other than having a good clinician, is I'm going to want a very strong office manager who can sell. This is assuming this isn't a huge office, which hopefully you're not buying a massive office as a satellite office. That could get rough, right? But you're buying a small practice, 4 ops, it's doing $40,000 a month. You're picking it up for $300,000. You guys would be a nice little satellite practice to have. Well, okay, so you get an associate doctor who's a decent clinician. I would definitely insist that they learn how to sell. But the more important thing to me at that point from a sales perspective is I want that strong office manager who can already sell. It might be somebody that I've trained through my practice as sort of a junior manager that I'm now going to move over there. because then they'll pick up the slack while the associate is learning to sell. It's very similar to the setup that you would have in your practice if you wanted to have the associate start helping you sell before training them. But again, you're going to have to make sure that they can at least comfortably discuss treatment options with patients and answer all of their questions. So that's all I have for you this week on that. I wanted to spend some time really looking at all the different scenarios so that you could kind of think with it depending on the situation that you might find yourself in. Obviously, this question has more than one answer. And really, if you want to look at it, ultimately, the best way of looking at it is someone has to be able to sell in the practice. Whoever's interfacing with the patient, at least one of the people, has to be able to close. I'm a fan of anybody who's in that role, or at least has a portion of that role, should have the skill set. So if it's the associate and an office manager, they both should know how to do it, or associate and treatment coordinator. If it's you and the treatment coordinator, anybody who's going to be touching, or a touch point for the patient with regards to treatment presentation should have some sales skills, because, the most important thing is really, if you look at it, it's not getting the close, it's getting the patient healthy, and you can't get them healthy unless they agree to do the treatment. Anyway, I hope that helps. If you have any questions about MGE, you can find us online at mgeonline.com or call us at 800-640-1140. Folks, have a great week, and we will see you at the next episode.